Hi everyone, thanks for joining us. We're just letting people into the webinar now, so we'll get started a little after midday, so just bear with us. Okay, good afternoon everyone. Welcome and thanks for joining us today for our In Conversation with Dr. Amy Gerrish, Dr. Helen Jenkinson and Katie Elliott. In today's webinar, we'll be hearing about Amy's work in diagnosing childhood eye cancer. We'll also be hearing from Helen about how this research might translate into clinical practice. And Katie's here to tell us about her lived experience of having childhood eye cancer. So before we get started, we have some housekeeping reminders for you. There will be live captions available during the webinar, as always. The slides, the transcript and a recording of the webinar will be made available to you after the webinar. So, please don't feel like you have to hurriedly write notes. You'll get all the information afterwards. That's it. This also includes people who haven't quite made it to the webinar today. So if you have any colleagues who intended to come and couldn't, they'll have access to everything too. There will be a Q&A session towards the end of the webinar if time permits. So please use the Q&A window within Zoom to ask any questions you have as you go along. We'll probably be answering the questions in a first come, first served order. And after the webinar, we'll be sending you an email which will include a survey, and we'd be really grateful if you could complete this, please, because it helps with planning future webinars and gives an understanding of the type of topics people enjoy and format. Okay, so now on to a little bit more of information about the webinar and me and our speakers. So I'm Emma Blamont, I'm the Head of Research and Programmes at Fight for Sight, and I'm joined today by Dr. Amy Gerrish, Principal Research Scientist at Birmingham Women and Children's NHS Foundation Trust. Amy researches a type of eye cancer called retinoblastoma, and she's received 2 grants from Fight for Sight for her work. She first received a small grant, which was co-funded by the Childhood Eye Cancer Trust, and more recently a larger project grant. With Katie Elliott, who was diagnosed with retinoblastoma when she was 4 years old. She's going to share her story with us all, and she's really keen to hear about what current research holds for the future for children like her. And finally, last but not least, we have Dr. Helen Jenkinson. Helen's a paediatric oncologist who can help shed light on how research like Amy's might translate to improvements in clinical practice. So before we kick off with the In Conversation part of the webinar, I'm going to tell you a little bit about us. We Fight for Sight. We fund the brilliant minds and bright ideas that put change in sight. And I'd like you to imagine for a moment, this is our brand story. Imagine that being told that you or someone you love is losing their sight. At that moment, you'll probably have two profound questions, which are, how can this be stopped, or can this be stopped? And how do I live my life? So we aspire that our work as a charity will help answer those questions. Over the next 5 years, we plan to distribute 30 million in grants across our scientific research and social change funding programs in the hope of saving sight and changing lives for those affected by vision loss. So today we're going to be focusing on our scientific research funding programme. Our researchers are working to better understand, diagnose, prevent and treat vision loss. So before we hear from Dr. Gerrish and Dr. Jenkinson, we're going to start with Katie to hear more about her experience of having retinoblastoma. So just a reminder, there will be a Q&A, so please put any questions you might have for your speakers in the Q&A window. Right, over to you, Katie. So
Hi, everyone. Oh, sorry.
No, that's fine. So you're an ambassador for Fight for Sight. You were diagnosed with retinoblastoma aged 4. Are you able to tell us a little bit more about, what it was like for you at that time, your memories of receiving treatment, and well, maybe you didn't know much about the diagnosis at that age. Maybe it was your mum and dad. Yeah.
So obviously being so young, being diagnosed with retinoblastoma at the age of 4, my memories are distant, but some of them are still there. So when I was diagnosed, my mum never really heard anything about retinoblastoma before. So she's obviously going onto the internet and Dr. Google is telling her all these things. So when I was diagnosed and she was told it was retinoblastoma, she got told off the doctors that it is probably a very high chance that I'll lose my eye. Um, so yeah, that's what she has told me. Some of my personal memories is actually going to the Royal London, and in the playroom, there used to be this pink gaming console, and that's one of my core memories playing with that. I also remember asking for a pink sparkly prosthetic eye. Um, I was told no at the time, but I'm actually on the search for someone who can make me one, which is very, very interesting. I also remember going when I was going through my chemotherapy, I remember some of my senses, such as my smell changing. Um, I used to always, after my hospital appointments, I always used to get treated to McDonald's. Um, so the smell of like certain foods was actually making me be sick, which isn't obviously ideal. Um, so that's one of the bad memories that I've got. Um, Another core memory, and I've actually got quite a lot of pictures, is dressing up in the playroom waiting for the doctors to come and get me. So that's some of my memories from being treated with retinoblastoma.
So I think that's sort of the sort of important role that the hospital has to in making young patients feel really comfortable and
Yeah.
at ease as well. It's nice to hear. So obviously, you're not a lot older, but you're older than
Yeah.
you were aged 4. So what made you want to stay in touch and become an ambassador for Fight for Sight?
So when Sarah reached out to me in August, September time last year, to be an ambassador for Fight for Sight, I was really, really excited. Um, I knew straight away that becoming an ambassador for the charity helped my dedication to awareness with sight loss and retinoblastoma, and obviously Fight for Sight's mission to preventing blindness and funding research. It all really stood out to me. Obviously growing up with sight loss made me aware of how important it is for obviously early diagnosis with retinoblastoma and obviously other eye conditions. So when Sarah asked me to become an ambassador, I jumped at the opportunity, should I say. So yeah, that's how I wanted to be an ambassador.
That's a really nice story, Katie. Thank you for sharing that. There's one question in the Q&A which I'm gonna ask now. I'm gonna sort of break with convention just because it might help people going forward with the webinar. So somebody's put in the chat, they just asked if they could ask what year you were diagnosed with retinoblastoma, if you could share that, please.
Yeah, so I was diagnosed in 2007, which is a couple of years ago now.
Yeah.
So I think the treatment lasted near enough until 2008, going into 2008. And then I think I got the all clear either end of 2008 or 2000 of start of 2009.
Okay. Thank you. So you had it. So yeah. So sort of first years of school, you were undergoing treatment as well, which must have been difficult for you.
Yeah,
Yeah, and your mum to manage
yeah.
as well. Okay, so I suppose looking to the future really, and making it a sort of better future for children who might be receiving diagnoses like the one you have had. So, as you know, Dr. Gerrish is a researcher who's been funded by Fight for Sight and whose research hopes to enable a better diagnosis for future generations. Are there some questions you'd like to ask her and Dr. Jenkinson?
Yeah, so Amy, what led you to a career in retinoblastoma research?
Well, hi everyone for a start. I guess it helps if I tell you a bit about where it's on my background and in my role. So I did a genetics degree and a PhD at Cardiff University, and that was on human genetics and disease. And I worked in academia, so in Cardiff University for a number of years in research. That's absolutely what I love doing, and especially in human disease. And I was working on identifying genes that cause certain diseases. Loved my job, but felt like I didn't really have it wasn't work that was going to have a direct impact to patients sort of immediately. So I moved into the NHS about 10 years ago now, moved to into Birmingham, into the Women's and Children's Hospital in the genetics laboratory there, and was looking at it's a diagnostic lab predominantly, but has some research within it. And so about 8 years ago now, one of the technologies that was sort of coming on board then, or people were starting to get excited about, was looking at something called cell-free DNA, which, as it sounds, it's DNA that's not in the cells of your body. It's just it's released from the cells, and it's just in the body fluids such as blood plasma is sort of one of the main ones that people look at. And what this means, this DNA comes from all cells. So normally if you look at a blood sample, you're just looking at the cells that are in, the DNA is in the cells of the blood. But this cell-free DNA is basically from all cells across the body, ends up in the blood plasma. So this means that, for example, if you've got a pregnant woman, the baby's DNA is in the mother's blood plasma. And also if you've got a patient that's got cancer, the DNA from the tumour is in their blood. So you can look for the tumour DNA in their blood. And this was really exciting because it meant that things like you didn't need to biopsy the tumour itself, you could just look at the blood DNA. But at this point, it was very, very early doors on everything, and nothing was in clinic at that point. And one of our colleagues, Helen and I colleagues, Dr. Trevor Cole, he was the consultant geneticist for the retinoblastoma service at the time. This is about 2016. And he had the idea that we could use this technology in retinoblastoma. And one of his main ideas was that this DNA, so tumour DNA from the retinoblastoma, could be in a patient's eye fluid, so that we could analyse that DNA from just taking a sample of their eye fluid. So he got some funding to look into this. No one had ever looked at this before. There was nothing out, nothing published. And then he asked, this is where I came on board, was asked to look at this myself. And our pilot data, we showed that, yes, you could see this tumour DNA in eye fluid, and you could analyse it, and you could see the genetic changes that had happened in the tumour. And so that's where it started. I'd say then so we got the sort of preliminary data, but it was a more complicated story than as these things always are, than we were hoping. So we needed more research funding to look at this. So that's where I then applied to Fight for Sight through the small grant and the project grant, and sort of took over the running, I guess, of the research from Trevor. So he retired in about 2022. He's still absolutely got an eye in on it. He still always wants to know because it's one of his passions. And I guess he's transferred that passion to me now. So yeah, so since about 2017, I've been working on this basically.
Yeah, no, that's really, really interesting. Yeah, no, that's really interesting. I've also got a question for Helen. So Helen, how do we currently diagnose retinoblastoma?
Yeah, thanks, Katie. So I think retinoblastoma is a little bit different from other childhood cancers in that the diagnosis is a clinical diagnosis. So we diagnose it on what it looks like, its appearance on examination, and not necessarily on a biopsy, getting a little piece of that tumour. And so most children will be picked up by either a parent spotting a problem, and that can sometimes be a whiteness behind the pupil, or a whiteness on the pupil on a flash photograph, where you would normally see two pupils are red, you would see one red, one white. And actually, even these days, someone else spotting that the photograph is different because they've spotted it on Facebook or some other platform. So parents spot a problem in the majority of children, and we have a small number of children who we are anticipating may develop retinoblastoma because of a family history. And those children are examined from birth. So they would be diagnosed with retinoblastoma probably on screening. So we'd be looking at that little one from birth, and then we would pick that up at some point in the first few months or possibly years of life. So it's a little bit different depending on whether we are anticipating a child developing retinoblastoma or not. But the pathway for all of these children is to usually be seen by a local ophthalmologist. In Birmingham, we cover almost the whole of the UK from Birmingham upwards. So we cover the Midlands and the North, and Scotland and Wales and Ireland and the Republic of Ireland. So children will normally see an ophthalmologist locally first, and then they will be referred to one of two centres in the UK that specialise in retinoblastoma. And that would be us in Birmingham with our big geographical patch, or the team in London who see almost the same number as we do, but a much smaller geographical patch. So that's how they're diagnosed. And once they get to us, children are diagnosed very quickly. They have eye drops put in, they have an anaesthetic to look into their eyes. Photographs are taken of their eyes, and usually on the day we first see them, a management decision is made about how we're going to go ahead and treat them.
Thank you so much, Helen. Amy, I've got another question for you, if that's okay. Could you tell us a bit about your small grant award with Fight for Sight and Childhood Eye Cancer Trust, and more recent, the project grant?
Yes, I can. What I might ask, though, my own question is, Helen, could you just give a brief overview of how the genetics comes into a diagnosis of retinoblastoma first, and then I can go on to talk about our sort of work.
Yeah, sure. So it's really important for us to know with as much certainty as possible whether a child has what we call genetic retinoblastoma or non-genetic, or you'll see it sometimes heritable or non-heritable. And that's because for children who carry a mutation of the RB1 gene in all of their cells, their eyes are at risk from birth, and those eyes are at risk up until later on in childhood. So it's really important when we see a new patient with retinoblastoma to understand, is this a one-off problem that we can deal with and hopefully the rest of their eyes are not at risk? Or actually, is this a problem which we have to be very careful about because the retina in the remainder of their eyes is actually at risk of developing new tumours? So we need to understand the genetics of retinoblastoma. And actually, it makes a big difference. And Amy's going to tell you how we would get to understand that. But if you're a little one with genetic retinoblastoma and you carry a change in your retinoblastoma gene in all of the cells in your body, then actually you will need to be examined very frequently under anaesthetic for the first few years of childhood. So for children with genetic retinoblastoma, they'll be seen under anaesthetic usually till the age of 3, and then they will be seen throughout childhood, and they're not discharged until the age of 16. For a child who is non-genetic and we've treated their tumour, then actually the follow-up is very different. Most of those children don't need anaesthetics to check their eyes. They don't have to be seen all their childhood. They can often be discharged very much earlier. And actually, for those children, there isn't a risk to their offspring, so that we can be very reassuring to those children that they are not going to hand on any genetic problem to their children. Whereas those with a germline mutation, not only are we thinking of that child's management, but we're also thinking of the future for them and their offspring. And it's really important that they understand that their offspring also need to have their eyes checked. So actually the genetics of retinoblastoma and whether they're germline or non-germline makes a huge difference to the pathway that they follow, not only for themselves, but for the rest of their lives and for their children's lives. Is that what you wanted me to say, Amy? Is that enough? Does that make sense?
That's great. So just what's the word, finishing off how it was diagnosed, genetics, why they decided how it was genetics, was to analyse the tumour DNA. You needed to analyse the retinoblastoma tumour DNA to find what had caused the retinoblastoma, and then you could decide whether you would then know that it was just in the tumour, it wasn't in all the other cells of the body. So you needed tumour DNA, and the only way that you could do that with an eye or with retinoblastoma was if an eye was removed as part of treatment, as yours was, Katie, and you would be able to access the DNA. Otherwise, the tumour DNA. Otherwise, it wasn't possible. Now, previously, that was one of the main treatments was to remove the eye. So we got the DNA quite frequently, quite regularly, but with amazing work that Helen now does with all the chemotherapy treatments we now have, it means that a lot of patients are retaining their eyes, and so which is fantastic for the patient. But as a geneticist, it means we're not getting that DNA to analyse, so we just can't answer that question of what type of genetic retinoblastoma they've got, and therefore they kind of almost have to go on a higher risk screening programme because we just can't rule it out. So this is where Trevor's idea came in, that we needed an alternative way to find DNA. And so we were looking in the eye fluid. And as
Amy,
I say,
Amy,
yes,
sorry to interrupt.
No.
Can you just explain for the listeners or the viewers what eye fluid actually is and how you might get it?
Yes.
Yeah.
So,
Thank
the
you.
eye fluid we're talking about, not to get too technical, it's called aqueous humour. It's at the front of the eye, in front of the lens. I think I'm right in saying that, Helen. And what the reason that this was decided upon was because this gets taken out of an eye before there's a certain chemotherapy where they inject it directly into the eye. And so to keep the eye pressure, you remove a bit of eye fluid first, and then you put the drugs into the eye. So this sample was already been taken, and it was just getting thrown away. And Trevor was like, well, we should look at this. It's got this special DNA that we're looking at that might have the tumour DNA in it. So that's where it comes from. Yes, it's aqueous humour is the full term. And so, yes, so we found that with our first grant, which was from the Wellcome Trust, we found that, yes, there is tumour DNA in there. But when you're looking at eyes that are being treated, the levels of DNA is really variable. So, and it's a lot of the time we were not getting enough DNA to be able to do our genetic analysis. Probably something like only 4 out of 10, so 40% of the patients we were looking at had enough DNA, which, you know, is not really, it's not good for patients. That 6 out of 10 we wouldn't be able to get a result from, and it's not great for putting into clinical service. So this, and what we'd found was that we could work out that it basically was how big the tumour was in the eye. If you had a big tumour, you got loads of DNA in the fluid. If it was a smaller tumour, there was less. And obviously, as the tumour was getting treated with chemotherapy, the tumour is getting smaller, and therefore there's less DNA. So this is where our project grant, our first small grant, sorry, came in. Was we thought we've just got to start taking this eye fluid earlier in treatment. The treatments that we were, when we were collecting it, they'd had like 4 to 6 cycles of chemotherapy by the time we got the eye fluid, just because of when that treatment is taken. But if we took it earlier, we were hoping there would be more tumour at that time, so more DNA. And that's basically what we found with Phytosight. Amazingly gave us our small grant. We looked at it. I think we did 10 patients with the small grant, and we could get a genetic result for 80%. So 8 out of 10 of those samples, which is just fantastic, because that's a much nicer number of people who are going to get a result. So so that's why we were with the small grant. And then with the fantastic, we need to, you know, validate this more. Unfortunately, 10 samples is not enough to be able to take it into service. So we then got our project grant, which is a much bigger 2-year grant. It funds more staff and the consumables, and we can really widen out what we're actually looking at. So we've now done on this particular part of the grant, we've now done about 40 cases. Again, still seeing about 80% coming through with a genetic result. So that's just fantastic. And we are going to hopefully be able to get this into service sometime in the next 2 years. But what also we've now to do with the project grant is sort of expand what we're even looking at, because we were just looking at what causes retinoblastoma. Can we find out the exact changes that have caused retinoblastoma, and then we can tell whether they've got this genetic or heritable or non-heritable version of retinoblastoma. There's some evidence coming out from America that actually other genetic changes in the tumour might make it more resistant to chemotherapy. So if we can find that out at the same time, it gives information to people like Helen and be like, well, this patient has this genetic change, which means they might not respond to this chemotherapy. And therefore they look at other treatment options. So that's something else we're doing as part of this grant, sort of just to expand exactly what we're doing. And you've just reminded me, because you said you were treated at the Royal London. So we are Birmingham. We are one of the 2 centres, Birmingham and London. But also with Phytosight, we've been able to form a collaboration with London. So now we are getting national recruitment into this study, which when you're looking at a rare disease is incredibly important. So I think, yeah, I'll stop there.
That's amazing. Yeah, no, that's really amazing. I didn't actually know that it was just Birmingham and the Royal London. So yeah, thank you for that. So what advances have you already been able to bring to patients?
Yeah, so what I was saying then, so in terms of the Phytosight work, so as I said, we've analysed 40 patients now under our research, and we've actually given that genetic information back to Helen and the rest of the clinical team. So that is already becoming part of their sort of management. So, and that's probably been the last year, I think we've been doing that. So that's already, I mean, I just still get an absolute thrill every time I get a genetic result, which I know is going to impact a patient and their family. So that is fantastic. What we've also been able to do through some funding from our BCH charity, so the Birmingham charity, is, remember I was talking about cell-free DNA and how we've obviously looked at it in tumour DNA, looking in eye fluid. But you can also look at it, baby's DNA, mother's blood. And as Helen was saying, there's a genetic or heritable version of retinoblastoma, where if there's a family history, the baby is at risk potentially of inheriting retinoblastoma. And so what we've developed is a prenatal test. So while the baby's still in the womb, we can take a sample of the mother's blood, identify the baby's DNA within that blood, and determine whether they have inherited the genetic change from their or whoever the mother, father. And so we can get a diagnosis that yes, they are going to develop retinoblastoma prenatally. Which obviously for the family is much better because at the moment it's all done sort of postnatal testing, because the only other option with prenatal testing was to do an invasive biopsy. So basically what's called a CVS. So you take a sample of the placenta, and there's a slight chance of miscarriage with that. So obviously families don't really want to go down that route. They much rather wait for the postnatal testing. But then there's obviously the worry of the families throughout the period of pregnancy. Then it's a challenge for us as laboratories to get that result as quickly as possible once we've got the baby's blood sample, and just the management. It normally means that even if a patient is negative, because of the amount of time it takes to show that they haven't inherited it, they've often already had to have a screening with Helen. So they've obviously already had been under anaesthetic. So if we can shove all of that prenatal analysis, then it just makes everything a lot easier. So that's something. So we've been doing that test that is in clinic, that's in the NHS, and is available nationally since about 2022. We got that in place.
Sorry, that's fascinating, Amy. Sorry, Katie. Can I just jump in and ask a question to Amy and Helen? So I was wondering, what sort of age would you start actually treating then a young child or a toddler or a baby that's been diagnosed as having retinoblastoma prenatally? You know, when would be the sort of intervention window?
So we would still treat them as soon as we saw a retinoblastoma. So knowing that they carry the genetic change tells us that they have a predisposition. And so it doesn't alter the pregnancy. We don't bring forward the delivery of the baby, but it allows us to know that that little one is at risk. And so it allows us to screen from birth. And we would try and see children who we know are gene positive within the first week of life.
Wow.
And so we screen all those children from birth on a very strict protocol. So we see them once a month under anaesthetic. And so it means that when they develop retinoblastoma, which is by far the majority, about 95% of children who carry the gene will develop retinoblastoma, we are able to step in and treat them straight away. And that means that we're treating them often at a very much earlier stage because we are looking for it. So it just allows us to put them into the screening program with that knowledge that we know they carry the gene. And so and we can just make sure that that is done in a timely fashion. We do, however, have a number of children who are born with retinoblastoma. And so although some children might be gene positive and not present for many months after birth, even potentially slightly older than that, we do have a number of children who are already born with tumours. So we know that it's really important, because if we see children at the very early stage with tumours, we treat them early. So it's, you know, it's not unusual for me to be using chemotherapy in little ones who are only a few days old. So we can offer children the same range of treatments, pretty much the same range of treatments, whether they're 2 weeks old or 2 years old.
Brilliant. Right, I'll go back. Sorry, Katie, I'll go back to you now. You haven't even finished, I imagine.
So thank you, Helen, for that. So what do you think, Amy, would be the next step in retinoblastoma research, so that we can translate findings into the clinical benefit?
Yeah, so obviously we're already doing a little bit of that, which is fantastic. I think one of the main, I guess, things that we really need to do. So retinoblastoma is a rare disease. You know, obviously when it impacts a family, it impacts them, but generally we only see about 50 cases a year between the two centres. And we are obviously already in a collaboration with those with London. So the real sort of globally, what is now needed is international collaboration to be able to increase patient numbers that are on the same studies, increase knowledge between centres of what analysis people are doing. And so we, Helen and I, are actually part of a European collaboration, which is sort of moving to look at the eye fluid work, but also come into blood plasma, which I'll come on to in a minute. And that is between 6, including ourselves, 6 European centres across Europe, where we're looking to do pilot studies together and then potentially like full clinical trials. So I think that is acknowledged that is necessary to be able to advance things quicker. As I say, I've been doing this since 2017, so it just takes a long time, mainly because of the sample numbers we're getting. So collaboration is key. Some of the other work, as I say, we're looking at, so we're looking at these other in eye fluid, looking at these other genetic changes, as I've mentioned, that we think might affect treatment response. So that's the sort of next stage, I guess, in eye fluid work once we get the diagnosis into clinic. And we're also looking at blood plasma in retinoblastoma and CSF, so cerebral spinal fluid, which is sometimes taken from certain patients depending on their prognosis. And that we're looking at that as a way of helping people like Helen determine what treatment is best for a patient, by just giving them a bit more information about the genetics. So I think that's what is there's. You know, we've started the ball rolling now with what's possible really, and so it's there's definitely still a lot to be done.
Yeah, no, definitely. Can I just ask, this is just a personal question of my own, how many types of treatments are there for retinoblastoma?
Well, Katie, that perhaps won't surprise you that things have changed a bit since 2007.
Yeah.
And so when we were treating young people in 2007, we had fairly limited options. And it was about that time that we were starting to explore different ways of using chemotherapy. So when you were diagnosed, the only way we used chemotherapy was actually into the veins, intravenously. And chemotherapy is a kind of blanket word for anti-cancer drugs, but actually they can be used in lots of different ways. So since 2007, we've developed techniques to use chemotherapy directly to target the eye. So we can either use chemotherapy into the artery that supplies the eye, and so it's a pretty technical procedure which involves a child being asleep under anaesthetic and having a very fine catheter placed into their circulation system, and this catheter is fed up to the point where the ophthalmic artery, where the blood supply goes to the eye, forms, and at that point the chemotherapy can be delivered, which means that the eye actually gets a much bigger dose because it's directly into the ophthalmic artery supplying the eye, but the body gets a much smaller dose, and so we're able to treat the eye more effectively with higher doses of chemotherapy, but not cause some of the side effects of chemotherapy. So we're able to do that. We're also able to, as Amy's already talked about, use what we call intravitreal chemotherapy. For a long time, the most challenging part of treating retinoblastoma with intravenous chemotherapy was the fact that the tumours on the retina responded really well to chemotherapy because they had a blood supply. So the chemotherapy came in with the blood supply, treated the tumour. But quite often we were left with seeds in the centre, in the jelly of the eye, called the vitreous. And they were really hard to treat with intravenous chemotherapy because we just had to let the chemotherapy diffuse from the bloodstream into the jelly of the eye. There's no blood vessels there. So quite often we would treat a tumour but not be able to control the seeds in the jelly of the eye. And so this procedure, which has led to Amy's work and allowed us access to aqueous fluid, has actually also allowed us to give chemotherapy into the jelly of the eye which is a much better way of treating seeds. So it means that we're now able to treat successfully many more eyes than we were at the point when you were treated. And so, so we have a much lower rate of needing to remove eyes surgically. And actually, we hope also that therefore we've got a higher rate of children who've got some sight, not necessarily normal sight, but some sight in their affected eye. So it's been a real story of change. I've been fortunate enough to have been with retinoblastoma since we started our service in 2002. So one day I'm going to write a book about how it's changed, because it really has been a success story of using chemotherapy innovatively and using research in such a way that it makes a difference.
Amazing. Thank you so much for that, Helen. All very, very interesting.
So I think we probably should start moving over now to Q&A questions from the audience, unless have you got any more questions, Katie? If you do, please feel
No,
free.
I don't think so.
Okay, they were great questions. I think they've opened up a really good discussion. And I think the work of Amy is, when you think about it, she said they've already given results to like genetic information or potential genetic information to 40 children, and given the numbers are actually diagnosed within the UK, I think this is pretty impressive. So hopefully this research is already having a brilliant impact, or good impact, positive benefit to lots of people out there that are affected by this condition. So opening up to the questions in the Q&A. Well, we've got one for you, Katie. It's actually more of a comment than a question, and it's about your pink sparkly eye that you're looking for. So somebody's put that the National Artificial Eye Service, I think that's what NAES stands for, can make you a custom order for any eye colour you like, apparently.
Oh, really?
Yeah, so maybe look them up, do a bit of a Google, National Artificial Eye Service. Yeah, so your wish might come true.
That's really interesting. I better ask my ocularist about that.
Can I jump in there as well, Katie? I'm guessing from your accent that you might be based north of the border.
Yeah.
And so there is a little bit of a difference between the artificial eye services north and south of the border, but that yes, our anonymous attendee is absolutely right, that as well as providing NHS eyes, there is a custom service. And if you look at their website, they do have some really quite wacky eyes that people have clearly chosen in the past. So I would encourage you to look at their website. They're fantastic, and they will, I'm sure, help you with what you need.
Amazing. Thank you so much.
Okay, right. So the next question we've got that's been submitted is, how does the new idea around testing relate to the current CVS? And somebody spelled it out as chorionic villus sampling test, which an expectant mum with a known history of RBE can undergo.
So yeah, so I think what we do, so with a CVS, you would have that taken, if I'm right, around 14 weeks, I think, in pregnancy, you would have that test. As I say, it does have a very low chance of miscarriage, but it is there. They would get a result, obviously, in that, so that does give the prenatal advantage to the family and to the clinicians. With our testing, with the blood testing, we do for most, we do this type of testing for other disorders as well, such as cystic fibrosis and some muscular dystrophies. And we normally take samples about 12 weeks in gestation then. But because with retinoblastoma, we can go much longer into pregnancy. So any time in the second and third trimesters, basically, we can take a blood sample and get an analysis back within, I think it's a 2-week turnaround time, something like that. And then that obviously that information goes to the consultant geneticist. So these, I mean, Helen might want to comment on this, but these individuals, because they've got family history, they should already be within our genetic service, and so will be already on the books, as it were, so that they will know that we want to do testing on any future pregnancies before the baby's born, hopefully, or postnatally if necessary. Hopefully that answers the question.
Okay. Thank you, Amy. We've got another question, which might be perhaps more for Helen, which was, when was the JOE protocol, JOE, for systemic chemo first implemented?
So the JOE protocol is the standard intravenous chemotherapy that we use, and it was introduced in the UK in 1994. And so, and actually what's interesting about it, it was introduced by my colleague, Dr. Judith Kingston, who sadly passed away a few years ago, but she was absolutely instrumental in introducing systemic chemotherapy and conservative therapy to the UK. And actually, we are still using the same protocol now. And so it's really hardly differed, although we don't offer intravenous chemotherapy to as many patients, because we've got intra-arterial, intravitreal, when we need it, which is often for children with bilateral disease, when we're treating both eyes, or when we've removed an eye and we know that there are some features that we call higher risk, and we know that that child will benefit from chemotherapy as well. It's really very, very similar to how it was back in 2007. So yeah, but 1994.
Okay. So things have changed, but you know, some of the first treatments, I suppose, first line of treatments are still sort of being used then in certain cases.
Yes, I mean, it's still a highly effective treatment for retinoblastoma, and our concerns about using the JOE chemotherapy are as much about the side effects of the treatment and not the benefit from it, because actually it works extremely well. But when you're treating a little one with intravenous chemotherapy, you do expose them to some longer term side effects. We've got newer ways of monitoring those, and we've got newer ways of giving some of the chemotherapy drugs to allow us to make a better judgment of how their body's handling it. But actually, you know, in terms of the chemotherapy itself, it's still a very, very good treatment for retinoblastoma, and it's used internationally.
Thank you. Thanks for clarifying that. And that sort of ties into another question about how the benefits of chemo have changed. So it sort of really explains that. So somebody's asked a sort of historical question. So they sort of asked, what would be, I'm not sure whether this is maybe somebody who was affected, has had, you know, been diagnosed with retinoblastoma in the past, you know, perhaps in the 80s. But somebody's asked, you know, what would have been the options for a patient, and particularly in terms of chemotherapy within the 80s or before?
There wasn't a standard protocol in the 1980s. I'm pleased to say I wasn't working in the 1980s, so it's not quite my era, but there wasn't a standard protocol. And so it was the early days of using chemotherapy as an adjunct to treatment for retinoblastoma. And some of the earliest chemotherapy was actually given by mouth. And so often it would be used alongside radiotherapy, sometimes plaque radiotherapy. But it would be used by mouth. So agents that are still useful, so things like cyclophosphamide, which I'm sure won't mean much to everybody here, but actually agents like that could be given by mouth. And that's where Dr. Kingston's work was amazing, because she gradually looked through the small clinical trials of our patients where she saw responses, and worked again collaboratively with patients and clinicians around Europe to work out what was the best standard treatment. But slow increase from the 1980s of oral chemotherapy such as cyclophosphamide, and then starting to use 1, 2, or 3 agents. And the JOE chemotherapy is 3 agents, so it's 3 different drugs that are used in combination.
That's helpful, thank you. And I think, I don't know whether this is the same person as somebody else. Somebody has put a very nice comment about Dr. Kingston, saying that she was a wonderful woman. So somebody very appreciative there of her. Okay. In terms of other questions, well, I think there's one actually maybe for me here. Somebody's asked, what are the Fight for Sight small grants and project grants? So I'll try and explain that without making a hash of it. So we offer a range of grants for scientific research at Fight for Sight. So our small grants are sort of smaller pots of money. They're for £15,000 for usually about a year's worth of work. And it's really to help if somebody's got a good idea and they want to sort of de-risk it by getting some preliminary data that shows that this idea works and, you know, is worth pursuing further in a sort of larger grant. It's really to sort of help with that, really sort of for more sort of pilot studies. And our project grants are sort of larger grants. They normally run for 2 to 3 years, 3 years maximum, and they sort of offer up to £250,000 worth of funding, and that typically pays for a researcher, a postdoctoral researcher, or a research assistant who works on the grant and does to deliver some of the research, and also, you know, all the consumables, the bits and pieces that you need to do the work. Okay, let's just check. Are there any more questions in the chat? Somebody's put a comment sort of saying that they find it amazing how much the testing for genetic risks and also the treatments have changed in the past 40 years. And they're very appreciative of the conversation and all the responses today. So that's nice to hear. Are there any more questions? I think we've probably answered everything. Hold on, I can see somebody type in, just check.
Emma, if I can just jump in while this person's typing, just to sort of say, following on from that, you know, that last comment about genetic risks, is that Professor Cole, who Amy referred to, did a study, an audit, quite a few years ago now, in the early days of our RB service in Birmingham, and actually demonstrated that people were making choices about whether to have children in the future based on information in their genetics, which probably wasn't as reliable or as accurate as it should be. And actually some people were making the wrong choices, so chose not to have a family, and based upon information that may not have been as reliable as it is now. So I think actually one of the additional impacts of the amazing work in genetics is that families have such a good and clear idea of what the risks are or aren't for their future offspring, which allows so many more families to make an informed decision. It's really important. And I'm now seeing families I'm calling a preconception clinic, but families are coming back having thought about what's now available from a genetic understanding and wanting to understand more about, if we went forward with a pregnancy, what would that little one be exposed to, what would the treatments be like. So it's really opened up a dialogue in the retinoblastoma community, which has been so helpful and overcome those kind of misconceptions from the past.
That's brilliant. So it's really having impact really across the board, which is helping people make informed choices. Right, before we wrap up, I just wanted to have one final question for Amy. And it's really thinking about how soon, Amy, do you think we will start to see this being sort of brought into services and seeing the benefit from this new, better way of diagnosis?
So for the iFluid work, where we're looking at diagnosis, saying whether someone's heritable or non-heritable, as I say, we are giving the results back to doctors sort of from the research, but that will be, we're applying now, there's something called the genomics test directory, which basically means that once it's on that test, the NHS pays for it. We need no more research funding. We can say, thank you very much, Fight for Sight. We can take this from now. And we're looking to apply for that to come online, hopefully next year would be the ideal. The other work, so looking at the treatment response and some of the plasma work, that's very much a work in progress. That will be, the clinical trials we're looking at will be, 10 years time, something like that. But yes, the actual diagnosis work should be soon.
Brilliant. This has been a really, really inspiring webinar, actually, sort of seeing something that's so close to actually patient benefit, and hopefully you're going to be delivering benefit to people in the near future. So I think, unfortunately, that's all we have time for today in terms of questions. So this slide, which you will receive in your slide deck, so no need to write anything down, has some useful resources about retinoblastoma, Amy's work, and more about the impact of phytocytes work in general, and also, importantly, all about Katie and her story. If you've enjoyed the webinar, we've got some more coming up in the webinar series. The next webinar is was really showcasing work from our social change funding programme. And it's called Building Confidence in Vision Impaired Children and Young People. And we're joined by Henshaws, based in Greater Manchester. And then in terms of our scientific research programme, the next research programme will be in May with Dr. Hannah Levis, who's developing artificial corneas. And some of you may be aware there's a shortage of corneas for corneal transplants. And for every transplant that happens, there are about 70 people in need, 70 others in need. So, please join us to hear more about how Dr. Levis's work is, sort of going to help ameliorate this situation. Okay, so thank you for joining us, and thank you again to our speakers today. I've really enjoyed this webinar, and we hope to see you again. And please, if you could answer the webinar survey questionnaire that you're going to be sent, we'd be extremely grateful. Thank you all, and we look forward to seeing you next time.
Thank you, everyone.
Thank you.